We're going to put all this together now with RAS and make sure that you're truly, truly familiar with the entire process of your RAS system. Let's begin. So here we are. Where? I want you to begin at the kidney. Please begin at the kidney. Okay. And why would you want to release your renin? Decrease perfusion to the kidney. Okay, good. Give me some differentials. I've walked you through renal artery stenosis adequately. What about congestive heart failure? Decrease perfusion to the kidney. In these cases, those juxtaglomerular cells are going to release renin. Hence, take a look, please. Decreased blood pressure is then going to release your renin. Here, continue forward. I want to make sure you're clear about this. You are going to be an MD. You're going to be a doctor. But that MD stands for macula densa. Macula densa with decreased blood pressure. Walk me through this. Initially, decreased blood pressure, decreased perfusion, decreased GFR. Where's my macula densa? Distal convoluted tubule. What's the name of that sensor? Macula densa. I showed you a picture earlier. What does a macula densa sense? It senses the sodium or chloride, right? And so therefore now, with decreased blood pressure, what's it doing? It's not sensing as much. So all of this is going to help contribute to increasing renin. One last thing. When you have a decrease in blood pressure, can I ask you what branch of the autonomic nervous system has to come out? Good. Sympathetic. What kind of receptor on your JGA? Good. Beta 1. Once again, yet another factor to help you stimulate renin. Here it comes out, and here's my OGIN. Now, I'd like for you to take a look at this suffix. I'd like for you to understand this concept. OGIN, 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 OGIN. What does that even mean? Trypsinogen, fibrinogen, angiotensinogen, so on and so forth. So the term OGIN means weak, precursor, right? Most of your proteins come from where? The liver. What's the most abundant protein in our bodies? Albumin. Coming from where? Liver. Here's angiotensinogen coming from the liver. What's that renin do? Cleave off the OGIN. There it goes. What do you have? Angiotensin 1. Where's that angiotensin 1 headed to? To the lung. What's there? ACE. So here, ACE, angiotensin converting enzyme, will take the 1 and turn it into the infamous angiotensin 2. Now, let's plug in some pathologies. Ready? What if you had a patient that ends up having too much renin autonomously? There was no decrease in blood pressure as an inciting event. And an imaging study, you ended up finding a tumor. Where? In the juxtaglomerular apparatus. Wow. And you ended up finding increased blood pressure. So you have an increase in renin, increase in aldosterone, and you have secondary hypertension. Are we clear? What is this called? A reninoma. So you understand the physio, you can easily put in the pathology, and you see your patient. You can actually see your patient. Next, give me a pathology in which your ACE might be elevated. A pathology. Maybe something like, what if I told you non-caseating granuloma, bilateral hilar lymphadenopathy, an African-American female? You would tell me, good, sarcoidosis. In sarcoidosis, you could have increased production of ACE. What does this mean? Increased production of angiotensin 2. Now, with all that said, let's say that you give an ACE inhibitor. When you have an ACE inhibitor, then you knock it out, and you can never form angiotensin 2. You'll never release your aldosterone. Stop there for 1 second. The branch that's important for us, bradykinin. ACE, angiotensin converting enzyme, is an enzyme that you must know as being the enzyme responsible for metabolism of bradykinin. Two major effects of bradykinin that you want to know as being a side effect of what drug? ACE inhibitor would be a dry cough, and number 2, what happened? No, not angioedema, right? So bradykinin, increased kappa permeability, and number 2 might be something like dry cough. And with that dry cough, which is incredibly irritating, you change the drug into ARBs. Got it? Let's move on. A few more. Angiotensin 2 vasoconstriction, preferentially what part of the arteriole? Efferent. What will it do to your blood vessels in general? It'll cause contraction, vasoconstriction. What are you trying to do? Increase blood pressure. What was the inciting event? Take a look, please. The first box. Over onto your left is decreased blood pressure. You're trying to increase your blood pressure. There's my efferent arteriole. What does it do? Do not memorize this. Close your eyes. Let me ask you a question. Number one, you have efferent arterial vasoconstriction. Tell me about renal blood flow. Renal plasma flow? Decreased. Next, efferent arterial vasoconstriction. Tell me about GFR. Increased. Give me the equation for filtration fraction. GFR over renal plasma flow. Good. You do the math. What do you get for filtration fraction? Increased. Good. Move on. What else happens? Well, angiotensin 2 is going to go where? That's the organ adrenal. Which part? Cortex. What part of the cortex? I'm going to keep pushing you here. What part of the cortex? Glomerulosa. Angiotensin 2 is going to work on the glomerulosa to stimulate what's known as aldosterone synthase. Here comes my aldosterone. Close your eyes. You know this from physio already. Aldosterone turns to your collecting duct. Aldosterone works on your principal cells principally. What does it do? It works on your sodium channels everywhere. What do you mean everywhere? Well, principal cell. You picturing that? Where am I? Collecting duct. Okay, fine. And it's facing whom? Urine. It's facing the urine. So that's known as the apical membrane. That apical membrane has a sodium channel, right? The apical membrane has a sodium channel. Aldosterone could work on that ENaC. It's called epithelial sodium channel. Epithelium sodium channel. ENaC. Aldosterone works there to remove the sodium from the urine. You know that already. Next, on the basolateral membrane only, you have your sodium potassium ATPase pump. So what kind of effect does aldosterone have on your pump? Tell me about that pump. Sodium being kicked out. Kicked out into where? Into your blood. Aldosterone will stimulate that pump. Read the rest of this. Insertion in principal cells. Enhances. Stop there. So you're going to reabsorb sodium. You're going to take out two. What do you mean take out? You're going to literally remove and secrete two substances into your urine. First will be potassium. Next will be hydrogen. Okay? You can see we're going to work through a lot of pathologies here, aren't we? Because you can have issues and you have too much aldosterone, and you can have issues in which you have too little aldosterone. Too much aldosterone, give me two differentials. Give me two differentials. Number one, con, exclusive aldosterone secreting tumor. Cushing. Cushing will be both cortisol and aldosterone. Give me one aldosterone deficiency pathology. Addison's disease. So, are these things that we talked about? Of course. Keep repeating it. So, whenever you have aldosterone, it'll reabsorb sodium, it'll kick out the potassium, meaning to say, urinate it out, and it gets rid of your hydrogen. So, in Con syndrome, what do you think? Tell me about the pH in that patient with Con. Take your time. Close your eyes. Reabsorbing too much sodium, getting rid of too much hydrogen. What happens to your pH? Increases. Alkalosis in Con. Confirm it. Why? Because you will find many patients with secondary hypertension and Con syndrome. Many. Not rare. Many. Creates favorable sodium gradient, and along with sodium, what comes out? Fluid. Fluid. Tell me, what is it that contributes to the pitting edema in congestive heart failure? The aldosterone. Why? Because of this entire mechanism we just went through. Are we done? Not quite yet, because you're decreasing blood pressure, but there's another hormone that also comes into play. And angiotensin 2, not only will it be responsible for releasing that aldosterone from adrenal cortex, but angiotensin 2 also works on the posterior pituitary. Why? Decreased blood pressure is what the kidney's thinking. This angiotensin 2 is then going to work on the posterior pituitary, and so therefore you're going to release ADH. Tell me about ADH. Antidiuretic hormone. That works on the also collecting duct. But what does it do? It works through your V2 receptors. How many kidneys do you have? I think one. No. Two. I think I have two. Yeah. You have two kidneys. So V2 receptors is what ADH works on. You gotta have fun with this just a little bit, huh? So it works on V2 receptors. And what does it do? It is then going to insert aquaporins. So that you do only what, please? Antidiuretic hormone. What's another name for ADH? Vasopressin. And you're only going to reabsorb water. In the hopes of doing what? In the hopes of restoring osmolarity. In the hopes of restoring some of your blood pressure. Now, a couple important things about angiotensin 2 in addition is that it does work, please pay attention, that's as proximal convoluted tubule. Angiotensin 2 earlier through aldosterone, let me ask you this question, worked where? Collecting duct. Angiotensin 2 here is working on proximal tubule. What does it do? It reabsorbs your sodium. Don't memorize this. What are we doing? There was a decrease in blood pressure as being the inciting event, right? Now the angiotensin 2 is going to work on your proximal convoluted tubule so you can try to remove more sodium in exchange for hydrogen. So water reabsorption and then can permit what's known as contraction alkalosis. And what that basically means is that you're going to have contraction, and along with it, you have also hydrogen leaving, resulting in alkalosis. Finally, in the hypothalamus, it has thirst. Okay, and all of this is then going to contribute to release of ADH. So, ladies and gentlemen, angiotensin 2, as you can see here, from the origin of it all, with that initial event of whatever it may be causing a decreased perfusion to the kidney, once you get into the renin realm, now renin, along with angiotensin 2 and aldosterone, my goodness gracious, right up and down the body, has all kinds of incredible effects. And all these pathologies that we're going to put in here, including some of our issues with ADH and diabetes insipidus, right? Central and nephrogenic. We're going to bring all this into play. But if your foundation isn't strong, it's going to make it quite difficult for me and you to work together so that we can accomplish our goals effectively.